Hi everyone. This is just an addendum to the last video I did on liver diseases. This is just going into the uh, other part of the liver, that is the ductal system. So disease of the ductal system of the liver. As you know, the ductal system is both intrahepatic and extrahepatic. Intrahepatic, they are called, in macroscopy, they are called hepatic ducts. Then they come out as bile ducts, joined together come out as bile duct. That's called common bile duct, CBD. That is in short what the anatomy is. But of course, the ductal, like all ductal systems, divide into small things, like bronchi, bronchioles, like that. It becomes something called, I think they are called, the small ones are called canaliculi. And by the way, all the diseases connected to the this one called ductal system is called as a the first word is cholangio. The cholangio refers to the bile duct. Cholangio. Choli means bile. Cholangio. Angio is maybe you can say it's a duct. Cholangio. So the duct which carries bile is called a cholangio. So if there is a cancer in a bile duct, it's called cholangiocarcinoma. Similarly, if there is an infection or inflammation in the bile duct, it's called cholangitis. It's all cholangio. Then this one. These are very common in the sense that one of the commonest diseases in old people is the gallbladder stones. Gallbladder stones. It's called coli. Again, refers to bile. Cholelithiasis. Cholecystis, the gallbladder. So cholelithiasis. Lithium means stone. It's called cholelithiasis. Another thing is the related entity. It's called a common bile duct stone. That's also pretty common in our old age. Common bile duct stone. Probably the etiology of these stones may be a little different. For example, inside the gallbladder, mostly cholesterol, whereas common bile duct stones can have pigment stones because more infection there. So when there is gallbladder stones and infection, it's called cholangitis. That will be heralded by, that will be denoted by signs of or evidence of inflammation and infection, like fever, rigor. Rigor means you will have the tremors. Body will have rigor. I think everybody knows what rigor is. Now, when you have fever with a lot of infection, especially the bloodstream infection, they get rigor. So same way, when you have gallbladder, bile duct infection, ductal infection, just like blood vessel infection, you get rigors, fever with rigors. The classical example of rigor is in malaria. But I don't know why there is the rigor in malaria. Probably it's also because of septicemia. It's another word for infection in the blood. That's called septicemia. So that produces rigor. Then they can have cholangitis, pain in the upper abdomen, because that is where the ductal system is located. So the most common is gallbladder disease or gallbladder stones are pretty common in old age. In fact, by the time you're 70 years, it's said that about 50% will have gallbladder stones because of some characteristics. There is more excretion of cholesterol into the bile. So it predisposes to cholesterol stones. About 90% of stones are cholesterol stones. Pigment stones generally comes from the pigment. Bile pigment is produced from the hemoglobin degradation products. So that pigment stones are, then they get infected. That's how they can be black in color. generally black in color, usually seen in the common bile duct, sometimes seen in the gallbladder also. So these are the common bile duct disorder. Then there is generally when they have bile duct problem, there will be stasis in the bile duct. Stasis because there is some obstruction there. It's called cholestasis. Cholestasis. So any disease which produces cholestatic jaundice means there is some obstruction in the bile duct. Cholestasis. Cholestasis can be diagnosed by blood tests. You don't have to, and imaging of course. The primary blood test is what's called alkaline phosphatase. There will be a disproportionate increase in alkaline phosphatase. It can be as high as 3 times normal value, and also the ratio of ALP, that is alkaline phosphatase, or this one, SGPT. The SGPT is otherwise called ALT. The ratio of ALT to ALP will be less than 2. Generally, this one AST values are, ALP values are more than alkaline phosphatase value. SGPT is usually at least double that value of alkaline phosphatase. But if it is less than that, if it is just 50%, that means there is bile duct, at least bile duct inflammation, or there is some kind of inflammation going on there. Then if it is 3 times more than normal of ALP, it's called cholestasis. But one has to keep in mind that the alkaline phosphate does not come from the bile duct alone. It comes from bone also. So the differentiating feature is there is another enzyme called GGT, gamma glutamyl transpeptidase, not transaminase, transpeptidase, gamma glutamyl transpeptidase. If GGT is also high, that denotes that there is hepatic injury or hepatic cholestasis, or this one bile duct cholestasis, rather than this one, rather than it is coming from the ALP is not coming, alkaline phosphate is not coming from the bone, but mostly coming, but it's not very specific. In the sense that GGT can also rise in people who consume a lot of alcohol. So you have to, but there is another, some nucleotidase is there, which is supposed to be more specific. I'm not going into the detail of that. But so already mentioned what are the gallbladder, bile duct diseases. It's one is the gallbladder disease, gallbladder stones, then CBD stones, cholangitis, 3 of them. Then the other things are the malignancies, like the malignancy of the bile duct system is called cholangiocarcinoma, whereas the malignancy of liver is called hepatocellular carcinoma. Here is cholangiocarcinoma. So cholangiocarcinoma, then there is gallbladder. Gallbladder is not cholangio. Gallbladder carcinoma is primary gallbladder carcinoma. It's called primary gallbladder carcinoma. I know there is 2-3 primary here. It is just a semantic, like essential, primary. But it could also be because there are secondaries there. For example, if there is any problem in the flow of bile with obstruction in the bile ducts, that's called cholestasis. Cholestasis can produce liver injury. It's called secondary liver injury. So like that, primary gallbladder carcinoma, there can be primary gallbladder carcinoma is an adenocarcinoma, but secondary means it is secondary to some process in the gallbladder, like there is something called a small that is what is that, porcelain gallbladder. It's gallbladder in X-ray will look like a porcelain vessel or something. A lot of porcelain calcification can be there. because of the stone, diffuse stone in the gallbladder wall. And the gallbladder, large gallbladder stone itself can predispose to gallbladder carcinoma. Could be that is the secondary, but primary gallbladder adenocarcinoma is more common. Then there is another carcinoma related to the duct system. It's called the duct. The common bile duct opens into the duodenum at a place called ampulla. It's called ampulla of Vater or somebody. So there can be specific tumor there. It's again adenocarcinoma. It is called ampullary carcinoma. Not very common. But it can produce bile duct obstruction. The two things which can produce more common bile duct obstruction malignancies, one is ampullary carcinoma, another one is carcinoma. Carcinoma means epithelial tumor. Carcinoma is the epithelial tumor. So carcinoma of the pancreas, head of the pancreas. That can also, because the bile duct opens into the ampulla through this thing. Actually, the pancreatic duct also joins there in the ampulla. So it is related to the head of the pancreas. So that's why the commonest cause of probably malignant cause of cholestatic jaundice is carcinoma of the pancreas. It's very common. But ampullary carcinomas are there. It is sometimes related to the what is called diverticular, colonic adenomatosis, colonic adenomatosis. So those who have a lot of adenomas in the colon and elsewhere in the duodenum, all the spaces, they have a predilection for this thing, carcinoma of the ampullary cancer. Yes. So these are the 2-3 cancers there related to the ductal system. Cholangiocarcinoma inside the ductal system, either intrahepatic, extrahepatic. And then there is the pancreatic cancer, head of the pancreas. Gallbladder cancer. Gallbladder cancer itself can involve the cystic duct, because connects to the ductal system through the cystic duct. Cystic duct is the duct of the gallbladder, and produce obstruction in the bile duct itself, produce cholestatic jaundice. So these are the way how you diagnose by the present clinical presentation. And coming to this one, other diseases which are, you can say, rare, but they are not rare, in the sense that about 1 or 2 people in 1 lakh, it's not that rare actually. 1 or 2 people 1 lakh can have these things. One is called a congenital condition. It's called biliary cyst. It used to be called choledochal cyst before. Choledochal cyst. This is a cystic dilatation of the ductal system, either intrahepatic or extrahepatic. When it is only extrahepatic, affecting the bile duct, common bile duct, it is called type 1. When it involves near the ampulla, it's called type 1. Then there is type 4, means it involves both the duct inside the liver and outside the liver. That's type 4. So type 1 is biliary. These are not that uncommon. You see it even in adults and old people. Sometimes it's incidentalomas, incidental finding. You do an ultrasound and find a big thing connected to the ductal system. That is called a biliary cyst, choledochal cyst. Even though it is there from birth, sometimes it manifests in later life. Manifests with bleeding. You can have bleed. It's called Sometimes it can have obscure melena, present with obscure melena, in the sense that you search the GIT, you don't see any source of the bleeding, but when you can see a trickle of blood coming out of the ampulla, that inside you have to suspect bleeding from the ductal system. So these are the ways it produce present. One is the bleeding, then it can have stones inside, produce inflammation, and also about 30%, especially the type 1, which affect the common bile duct, can become cholangiocarcinoma. Then it predisposes to the formation of cholangiocarcinoma. So that is I'm sure not many people would have seen this, but it's not that uncommon. But 1 or 2 in 1 lakh. Then again, 1 or 2 in 1 lakh is there are two primary biliary conditions. One is called primary biliary cirrhosis, by PBC. Then it's another called PSC, primary sclerosing. Sclerosing means fibrosing, fibrosis, scarring. Primary scarring cholangitis, a primary sclerosing cholangitis. Cholangitis means inflammation of the thing. What happens is there is the difference between PBC and PSC is that in PBC it affects the primary biliary cirrhosis affects the liver primarily, and also the inside the liver, and it affects small, even canaliculi, smaller this one bile duct. Biliary obstruction is there in primary biliary. You get high ALP level, alkaline phosphatase level. So biochemically there will be high alkaline phosphatase. Clinically they don't present a jaundice, so it can be for a long time asymptomatic without any symptoms. But they will develop later on. They will develop 2 things. Main things. One is pruritus. Pruritus is a medical term for itching. So itching, generalized itching. Don't think itching gives you a lot of pleasure. Not with pruritus from primary biliary cirrhosis in any case. Then a lot of itching will be there. That is the main problem with the primary biliary cirrhosis, and they will have a lot of unaccounted for what is called fatigue. Fatigue means you are at the fag end. Fatigue. And so the person with fatigue, itching, no jaundice. And of course cirrhosis is sequelae. Cirrhosis sequelae is bleeding from the stomach, esophagus, and also all the other things. They go into cirrhosis. When anybody goes into cirrhosis, they go into hepatocellular carcinoma. So it can predispose to hepatocellular carcinoma. Whereas the primary sclerosing cholangitis, that also predisposes to carcinoma, but it's cholangiocarcinoma. It's called cholangiocarcinoma. Don't think cholangiocarcinoma is more benign than the hepatocellular carcinoma. No, it's not. You cannot remove it like that and get away with it. But cholangiocarcinoma is prognosis as bad as hepatocellular carcinoma. So this primary biliary cirrhosis generally present with typical biliary obstruction, like stone. They will present with this one high jaundice, then right hypochondrial inside this part, right part. I have to show the left side for it to see that it is right. Anyway, this part, just below the rib cage, right hypochondrial pain. They can also present with itching, all those things, usually associated with biliary stasis. So these are the 2 things, and the diagnosis generally in primary biliary cirrhosis, it is you have to check as what's called antimicrosomal antibody. If the antimicrosomal antibody is more than 1 is to 40, and you have high ALP, and you have evidence of little evidence of cholestasis like itching, fatigue, and all that, you have 95% diagnosis. You don't need a liver biopsy to diagnose this one primary biliary cirrhosis. And that's how you diagnose it. And of course, treatment is there is one drug called the ursodeoxycholic acid. It's a cholinergic. It's supposed to reduce the biliary stasis a little bit. So it can be given in about 15-20 milligrams per day. 15-20 milligrams per kilogram per day for a person. So that's not about the only treatment. And the other treatment is when it goes into terminal stages with cirrhosis and all those problems, hepatocellular problem, liver transplantation. For all these things, liver transplantation. Primary sclerosing cholangitis, liver transplantation. Primary sclerosing cholangitis, there is no other treatment. So probably palliative, you can, if there is a dilated ductal system, you can, and with stones in it, you can do an endoscopic sphincterotomy through the ampulla of the duodenum, take out stones or put some stents there. If it is a tumor, you can't do anything about it. You put a metallic stent, because metallic stent stays there permanently or till it becomes bad. But if temporary means they put a plastic stent. Metallic stents would be palliative, more palliative, metallic stents. So more, the wider metallic stents. So metallic stents. Of course, if the like carcinoma of the pancreas causing, head of the pancreas causing obstruction of the common bile duct, there is a surgery also there. You can connect the gallbladder, drain the gallbladder. It's called draining the bile. Draining the bile gives some palliation. From itching, for this one, fatigue and all that, that gives some good palliation. So draining the bile, first option is endoscopic. The second option is not recommended in geriatric textbook, but I have seen it done when I was, even I think as a Taluk hospital surgeon, I did on one man for this one, gallbladder to biliary, the intestine, generally jejunum, cholecystogeginostomy. It's called cholecystogeginostomy. That is a palliation. But the problem with surgery, these people are not fit for surgery. Mortality will be very high. All these people, I'll tell you my own the same experience. One man came with this gastric obstruction. Gastric means the stomach outlet, where the stomach goes into the thing, some kind of malignancy blocking that. What we do is, so we do a surgery called gastrojejinostomy. But these old invalid people, you should be very careful doing it, because it broke down. I did the thing, it broke down. But of course, I was not that experienced. It is soon after my MS, and it broke down. And then, but for the people don't know, the people don't know what this thing. It's a cancer, but the prognosis is not that good. But it's a palliative procedure. People don't know. But I suggest you do once more. They are not willing. So it's like this. I like that. So very careful in doing surgery in people like this. Palliation means you do endoscopy. Endoscopy first. Even any kind of palliation, do endoscopy. Gallbladder, seeing stones are there, try endoscopy. Of course, cholecystectomy if they are fit. Gallbladder carcinoma, cholecystectomy by all means. With a marginal liver, if you can do it. But think about the prognosis or the management after the surgery. Or if something goes bad, wrong, you are doing something. In fact, during my first surgical career, a senior surgeon advised me, don't do all these risky surgeries. He's right. So we always send for palliation there. Any number of gastroenterologists are there. They will do all these things, endoscopy and do it. So these are about the things in biliary disease, and of course, even cholestasis can be produced by drugs also. So there are two types of ways with it's called DILI, 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 drug-induced liver injury. Drug-induced liver injury, 90% is caused by 90% results in hepatocellular damage, 90%. But about 10% will present with cholestasis. For example, somebody is getting this one, this people give the testosterone analogs for, this athletes and all that. They can get this thing kind of hepatic injury without inflammation. This one, biliary stasis. Biliary stasis because of drugs, reaction to the drugs, biliary stasis, intrahepatic biliary stasis. Because the canaliculi will get clogged by inspission. They say inspission by something. So it's a non-inflammatory thing. But inflammatory can also be caused. Some drugs cause. But the drugs in the class, commonly we prescribe amoxicillin, erythromycin, the antifungal terbinafine. All these can produce inflammatory biliary stasis. Inflammatory biliary stasis. And sometimes what happens is the small biliary canaliculi can become atrophied later on. You won't see the ductopenia. It's called ductopenia. Ductopenia can happen inside the liver. So after some time, so if it is chronic means if you expose the person to more than 3 months of this thing, drug exposure, they can get chronic. More than 3 months is chronic, less than 3 months is acute. Most of the cases, more than 2 weeks is chronic, less than 2 weeks is acute. But here, more than 3 months of exposure will produce a chronic this thing. They can have ductopenia. And so diagnosis, they will have the same like primary biliary cirrhosis or something. But you have to make a diagnosis by probably do a liver biopsy to see the ductopenia. So these are some of the things. And this is just an addendum to the the last thing I did, the liver. And we will go to some other thing. Most of the things I finished. I think GIT, I'll finish with this one. CNS I finished, probably a few topics left. Then CVS I have finished. And of course, some general things are there in geriatry. Of course, this urinary abnormalities I have finished, and the incontinence I have finished. These are main things: incontinence, urinary abnormalities, incontinence, urine, feces, incontinence, falls. People fall. So I have done the autonomic neuropathy in old people and all those things. So most of the things in geriatry I finished. I'll see what is there left. And the sayonara. Okay. Thank you very much.